Hello everyone in CardioMinds channel and welcome to the third video for the guidelines of infective endocarditis. And today we are having an interesting topic, but of course too much information, so prepare a cup of tea or cup of coffee in order to concentrate with me today as we are going to speak about treatment of infective endocarditis. We are going to talk about many facts today before we go in depth for the treatment. First of all, regarding the antibiotic regimen, of course, bactericidal antibiotics are more effective than the bacteriostatic ones, both in animal experiments and in humans. Of course, the most famous antibiotic combinations are the aminoglycosides, which inhibit the protein synthesis, and they synergize with the cell wall inhibitors. The famous examples for them are the beta-lactams like penicillins and cephalosporins, and also the glycopeptides like the vancomycin, teicoplanin, and linezolid. They both shorten the duration of therapy for oral streptococci, for example, and eradicating any problematic organisms. However, the most important problem are the side effects of aminoglycosides, especially nephrotoxicity. And so there is another combination that could be used as a substitute, which is the ampicillin with ceftriaxone, because they are less nephrotoxic and effective in treating Enterococcus faecalis. We have a famous terminology called tolerant microbes. They are not resistant. That's why we call them tolerant, as they are susceptible to gross inhibition by the drug. But unfortunately, they escape drug-induced killing, and so after discontinuing the antibiotic, they may resume their growth. They are slowly growing and dormant and usually show phenotypic tolerance toward most antibiotics except rifampicin to some extent. They are usually present in the vegetation and especially in the biofilms present around the prostatic valve in case of prostatic valve endocarditis. That's why this justifies the need for prolonged antibiotic therapy for full sterilization of the infected heart valves. That's why these organisms need bactericidal antibiotics and also drug combination, for example combining ampicillin and ceftriaxone for Enterococcus faecalis, for example. And of course in many cases they need adding rifampicin. When we compare prostatic valve with native valve endocarditis, of course the duration of treatment for the prostatic valve endocarditis lasts longer, for at least 6 weeks or more. For native, it is 2 to 6 weeks. So for example, if the patient improves after 2, 3, or 4 weeks, we can stop antibiotics if we have evidence of complete resolution of the infection. But in the prostatic valve, at least 6 weeks. For example, in staphylococcal prostatic valve endocarditis, the regimen should include rifampicin whenever the strain is susceptible. Some data may show that there is no difference in the outcomes between patients with prostatic valve treated with rifampicin versus those treated without, but still rifampicin is a cornerstone for prostatic valve endocarditis, especially caused by staphylococci. Just to note, in case of native valve endocarditis needing valve replacement by a prosthesis, the post-operative antibiotic regimen should be that for the native valve, not for the prostatic valve endocarditis, the original type of infection. In both types, the duration of treatment is based on the first day of effective antibiotic therapy, not on the day of surgery. For example, the follow-up blood cultures that showed negative for bacteria, this is the first day to be included to calculate the duration of the antibiotic treatment. And of course, when you excise the infected valve or the infected prostatic valve and send it to culture, if it shows a different organism, so you should follow a new course of antibiotic therapy. The classical family of antibiotics to be used for infective endocarditis are of course the aminoglycosides. They are not recommended so far in staphylococcal native valve endocarditis because their clinical benefits have not been demonstrated. But when indicated in other conditions like resistant oral streptococci, they should be given for maximum 2 weeks, not more than this, to reduce the risk of nephrotoxicity. The most famous one, gentamicin, its dose is 3 mg per kg per day with a maximum dose of 240 milligram per day, given in one dose, not divided on 3 doses, because it is more bactericidal and less nephrotoxic. And you should have weekly monitoring of the kidney function and, if possible, serum gentamicin concentration. Optimally, you should have a pre-dose trough serum concentration for gentamicin that should be less than 1 milligram per liter, and if possible also post-dose peak, which is 1 hour after the injection, serum level that should be nearly 10 to 12 milligram per liter. If possible, it optimizes the level and the efficacy of gentamicin. Another classical antibiotic is vancomycin, which is a famous glycopeptide inhibiting the cell wall of the bacteria. Its dose is 30 mg per kg per day, intravenous, divided in 2 doses. So the gentamicin is 3 mg per kg per day, vancomycin 30 mg per kg per day. However, its dose should not exceed 2 grams per day unless serum levels are monitored and can be adjusted to obtain a peak plasma concentration of 30 to 45 microgram per milliliter 1 hour after completion of the IV infusion. As we know, vancomycin is given by infusion over saline, not a shot like gentamicin, because it may result in allergic reaction, and the most famous one, the red man syndrome. Rifampicin, or sometimes called rifampin, both are correct, should be used in case of foreign body infections. The most famous one is prostatic valve endocarditis. After 3 to 5 days of effective antibiotic therapy, and once the bacteremia has been cleared, use rifampicin. Why? Because it has an antagonistic effect for the planktonic replicating bacteria, and also it synergizes with the other antibiotics against dormant bacteria that are commonly to be present within the biofilms around the prostatic valve, and also it prevents rifampicin resistant variants. Daptomycin is another famous antibiotic that has been recommended for treating staphylococcal and enterococcal infective endocarditis. It must be given at high doses, nearly 10 mg per kg once per day, to be combined with a second antibiotic, either a beta-lactam, or if the patient is allergic to beta-lactam, fosfomycin, in order to increase the activity and avoid resistance. Just a note that fosfomycin may be associated with increased risk of acute heart failure, which is a common complication in infective endocarditis, and also renal failure due to its high sodium loads, and daptomycin may be associated with something called eosinophilic syndrome in up to 15% of patients, so we should be cautious about these side effects. The main concept of treatment is the empirical therapy. After you withdraw 3 sets of blood culture at 30-minute intervals, you should start your antibiotic therapy as an empirical therapy. Of course, the initial choice for the antibiotics depends whether the patient received previous antibiotic therapy or not. He has native valve, early prostatic valve, or late prostatic valve endocarditis. What was the setting of the infection? Was it community acquired, nosocomial, or non-nosocomial but healthcare associated infection? What is the local epidemiology in the hospital for the antibiotic resistance and the culture negative pathogens? So we should follow the local protocol for the hospital in which the patient is treated. And of course, just to remind, cloxacillin cefazolin administration has lower mortality rates than other beta-lactams, including amoxicillin clavulanic acid combination or ampicillin sulbactam, and also vancomycin for empirically treated methicillin sensitive Staph aureus endocarditis. However, the combination of amoxicillin with clavulanic acid or ampicillin with sulbactam, as we know, clavulanic and sulbactam are beta-lactamase inhibitors, so they are commonly administered with amoxicillin or ampicillin in the same preparation to increase its efficacy against bacteria. It may be an effective empirical treatment for methicillin sensitive Staph aureus, and then de-escalated to cloxacillin or cefazolin after 4 days from the index blood culture. So this combination is still valid. For native valve endocarditis and late prostatic valve endocarditis, they nearly have the same empirical antibiotic therapy that should cover staphylococci, streptococci, and enterococci, whereas coagulase negative should be covered in case of prostatic valve endocarditis, especially the early type, which is usually in the first year after surgery, not in the native valve endocarditis, because it is not common for the coagulase negative to cause native valve endocarditis. And for early prostatic valve endocarditis or healthcare associated infection, the antibiotic regimen should cover methicillin resistant Staph aureus, famously called MRSA, enterococci, and non-HASIC gram-negative pathogen, because they are common culprits for these types of infection. Then the laboratory will send you the results of the plaque culture, usually within 1 or 2 days. In this case, you know the detected organism, and so you adjust the antibiotic therapy to choose antibiotics that you expect this organism is sensitive to. But just a note, the laboratory will not send you after 1 or 2 days the results of the antibiogram, meaning the antibiotic sensitivity, because it takes longer time, at least 5 or 7 days. But from the detected organism, you know from literature what is the most effective antibiotic therapy for this organism. So the recommendation of the guidelines that there is a class 2A, that patients with community-acquired native valve endocarditis or late prostatic valve endocarditis, here the definition is more than or equal 12 months after surgery, you could choose ampicillin in combination with ceftriaxone or with flucloxacillin, and also combine with gentamicin. This is the empirical therapy for these types of infection, and here's the doses for the adults and also the doses for children. And beware of the precautions regarding gentamicin administration. But what about early prostatic valve endocarditis less than 12 months after surgery, or nosocomial or healthcare associated infection? There is a class 2B to give vancomycin or daptomycin combined with gentamicin, and rifampicin may be considered as an empirical antibiotic therapy for these types of infections. So there is a difference in the empirical therapy of the early prostatic valve endocarditis from the late prostatic valve or the native valve endocarditis. And here's the adult doses and also the pediatric doses for these types of infection. What if the patient has native valve or late prostatic valve endocarditis, but he is allergic to penicillin? In this case, there are alternatives. Cefazolin, but beware, cefazolin is a cephalosporin and common in patients who are allergic to penicillin to have cross allergy to cephalosporins and all beta-lactams. So another alternative is vancomycin in combination with gentamicin. So this is a patient with native valve or late prostatic valve endocarditis, but you have chosen vancomycin and gentamicin due to the allergy to penicillin or to all beta-lactams. And here are the doses for the adults and the doses for the pediatric patients. Then in the full text of the guidelines, you will find the specific antibiotic regimen for each type of organism. For the oral streptococci, whether they are penicillin resistant or sensitive. For the streptococcus pneumoniae. For the Staph aureus, coagulase negative staphylococci. For the MRSA, enterococci. For the gram-negative bacteria, either HASIC or non-HASIC. Should I keep in my mind all the specific antibiotic regimen for each type of organism? No. You should know by heart the empirical regimen for each type of infection. Then after the laboratory send you the results of the plaque culture, in this case you adjust your antibiotic regimen after you check the full text of the guidelines or the literature for the recommended antibiotic therapy for this type of organism, and you will find specific recommendation for each type of organism. And of course I put the reference in the description below the video for the full text. What if the patient has fungal infective endocarditis, which is frequently observed in prostatic valve endocarditis, people who inject drugs, immunocompromised patients? Of course, the most two famous fungi are the Candida and Aspergillus. The problem that it has a poor prognosis with high mortality rate, more than 50%, necessitating combined antifungal treatment, not just one. And of course, the response to antifungals is poor, and most patients need surgery. If I suspect that the patient has candidal infective endocarditis, in this case I use echinocandine at high doses or liposomal amphotericin B plus minus flucytosine. But if I suspect Aspergillus, in this case I can use voriconazole plus minus echinocandine or amphotericin B. Of course, you should tell the laboratories that you suspect fungal endocarditis in order to arrange for fungal culture and detect the specific fungus. But sometimes you can predict from the setting. For example, patients who are IV addicts, I can suspect which type of fungus is causing this infection, and we are going to speak about this later. And of course, most of those patients need suppressive long-term treatment with oral azoles like fluconazole and voriconazole. If the patient was lucky and he had conservative treatment that led to resolution of the vegetation, long-term treatment is recommended to prevent relapse. There is a controversial concept that started to be introduced in the guidelines of 2015 for infective endocarditis, which is the outpatient parenteral or oral antibiotic therapy. For more than 60 years, it had been considered that antibiotics should always be intravenous. However, the POET trial shows that after an initial phase of IV antibiotics, up to 20% of patients can complete the treatment by oral antibiotics, and so they could complete this at home if they are stable. And the 5-year outcomes showed continued effectiveness of the oral antibiotic therapy as compared with IV antibiotics for infective endocarditis in selected patients. So the antibiotic therapy consists of 2 phases: the initial or the critical phase, at least 10 days and up to 2 weeks of hospital IV antibiotic combinations of rapidly bactericidal antibiotics in order to destroy planktonic bacteria, and in this case, if the patient has a frank indication for surgery, it should be performed to remove the infected valve or infected foreign body and drain any extra cardiac abscesses. And the second phase, which is called the continuation phase, beyond 10 days of therapy or 7 days after surgery, I can start outpatient parenteral or oral antibiotic therapy as a step down, and it can be done at home if the patient is clinically stable for up to 6 weeks to eliminate any dormant or tolerant bacteria and prevent relapse. So in this case, I can discharge the patient but with meticulous follow-up at home. So which patients can be considered for the outpatient treatment? Patient is clinically stable, so he became afebrile during the initial phase with reduction of the CRP, white cell count, and the vegetation size is decreasing. The home environment is stable with a cohabitant caregiver that can take care of the patient's medications, and of course the patient should be self-reliant in order to trust his compliance to the medications. But there are important contraindications that prohibit you from thinking for the outpatient treatment for this patient, like presence of heart failure. This is a complication that is an indication for surgery, so I cannot discharge this patient. Patient with severe valvular regurgitation, so this patient may develop heart failure, or vegetation more than 10 millimeters, so we have high risk for embolic complications, or progression or local periannular complications, so the infection is worsening and most probably the patient would need surgery. Patient had neurological involvement due to CNS embolic complications. Patient had renal impairment, either iatrogenic due to the antibiotics or due to renal emboli. Patient has evidence of malabsorption, so he cannot take oral medications, they will not be absorbed, and so he should depend on the IV antibiotics. And of course, people who inject drugs are very high risk for relapse, either due to taking medications outpatient or due to the resistant bacteria. So this diagram illustrates what we discussed regarding the early critical phase, in which you start IV rapid bactericidal combinations in hospital, and if there is an indication for surgery, go for it. And then the continuation phase, in which you can start from day 10 post-treatment or day 7 after surgery, outpatient parenteral or oral antibiotic therapy in stable patient, but take care to perform transesophageal echo before switching to the outpatient treatment to exclude any local complications that may necessitate surgery, like abscess, dehiscence, or any signs of perivalvular extension. This table also shows the critical phase and the continuation phase for the 3 types of infective endocarditis: the native valve, prosthetic valve, and cardiac device-related infective endocarditis. And this table shows you what are the best antibiotics to be prescribed outpatient for the continuation phase according to the organism detected in the blood culture. And also this diagram simplifies to you how to decide for the outpatient treatment. Patient has definite infective endocarditis, so ask yourself, does this patient has a blood culture showing either Staph aureus, streptococci, coagulase negative staphylococci, or enterococcus faecalis? If he has no evidence for any one of these organisms, so in this case I predict that this organism is not suitable for oral antibiotic treatment and I should continue IV antibiotics. Then infection control. If the patient is having satisfying response to treatment, that he is afebrile after more than 2 days, CRP descent to less than 25% of the maximum measured value, or less than 20 milligram per liter, or white cell count less than 15, and treated with relevant IV antibiotics for more than 10 days or 7 days after surgery. If the answer is no, so the patient is not suitable for oral antibiotic treatment. But if the answer is yes, I ask another question. Does the patient have any other indication for continuing IV antibiotics, or body mass index more than 40, or faulty gastrointestinal uptake? In this case, if the answer is yes, so the patient is not suitable for oral antibiotic treatment. But if the answer is no, perform a transesophageal echo to check whether the patient has a new surgical indication or not. If he has any evidence for abscess, pseudoaneurysm, or dehiscence, so he is not suitable for oral antibiotic therapy. If the answer is no, so the patient may be shifted from IV to oral antibiotics, but of course to drug strategy. So the recommendation for the outpatient treatment, that there is a class 2A to consider it for patients with left-sided infective endocarditis caused by streptococci, enterococcus faecalis, Staph aureus, or coagulase negative staphylococci, who were receiving appropriate IV antibiotics for at least 10 days or at least 7 days after surgery, but the patient is clinically stable, do not show any signs of abscess or any periannular complication or valve abnormality that require surgery, after performing transesophageal echo to exclude local complications. And the big no, that there is a class 3 to shift to outpatient parenteral antibiotic treatment for patients with infective endocarditis caused by highly difficult to treat microorganisms. These are the organisms requiring IV antibiotic combinations that cannot be administered as outpatient or require strict monitoring for drug levels in the blood due to their potential toxicity, for example, vancomycin or sometimes high dose of gentamicin. Let's give some examples for this. MRSA or vancomycin resistant enterococci, multi-drug or extensively drug-resistant gram-negative bacilli, highly penicillin-resistant oral streptococci, and of course fungi other than Candida. All of these are difficult to treat organisms that should be treated in the hospital. Also, liver cirrhosis child B or C, severe CNS emboli causing strokes or intracerebral or subarachnoid hemorrhage due to mycotic aneurysm, untreated large extracardiac abscess like, for example, splenic abscess or spondylodiscitis, heart valve complications that need surgery or other severe conditions requiring surgery, severe post-surgical complication if the patient had valve replacement, and of course, people who inject drugs should continue their treatment in the hospital for treating the infection and starting psychotherapy in order to prevent relapse into drug use. So another diagram, you diagnosed a patient with definite infective endocarditis according to the Duke's criteria for 2023. You start empirical antibiotic treatment and then you admit the patient either to a heart valve center if available or admit to a referring center. Then after the results of blood culture appear, adjust your antibiotic treatments. Then an endocarditis team should be involved in treating this patient with frequent communication with the larger endocarditis team and the heart valve center. Then check for the presence or absence of any complications that may need the involvement of larger specialties in the endocarditis team in order to decide whether this patient would need surgery or any other specific treatment. And after the surgery, if the patient is stabilized, we can consult for the possibility of outpatient antibiotic treatment. This diagram focuses on the issue of recurrence. Either it is a relapse, which is a repeat episode of infective endocarditis caused by the same microorganism and represents a failure of treatment, or reinfection, which is caused by a different microorganism, usually more than 6 months after the initial episode. So, two types of recurrence: either relapse, which is commonly caused by inadequate antibiotic treatment, resistant microorganism, Staph aureus or enterococci are very common to relapse, polymicrobial infection in people who inject drugs, periannular extension, this patient had persistent unresolving infection and mostly would need surgery, persistent metastatic foci of infection like extracardiac abscess, prostatic valve endocarditis is more common to relapse than the native valve, persistence of fever at the 7th day post-operative, presence of chronic kidney disease, especially patients on regular dialysis, poor oral hygiene. All of these cause relapse, and in this case the patient should be treated by the IV antibiotics for additional 4 to 6 weeks according to the causative organism detected in the culture and its antibiotic susceptibility. And of course, cardiac surgery would mostly be required in this case. But for the reinfection, it should be treated by a different antibiotic regimen according to the new causative microbe. We mentioned that it is a new organism and mostly more than 6 months after the previous episode, so draw another plaque culture and detect the microbe and its antibiotic susceptibility. So we have reached the end of this long, exhausting video. Our take-home message: whenever you diagnose infective endocarditis using the Duke's criteria and withdraw 3 blood cultures, start your empirical antibiotic therapy, and when the result of the cultures appear, check the reference of the full text for the specific antibiotics for this organism to adjust your therapy. And check patient stability then after the initial phase to check whether the patient can be switched to outpatient parenteral or oral antibiotic therapy, or he should continue his treatment at hospital. Thank you very much for watching this video, and wait next week for the complications and indications of surgery for infective endocarditis.